Good morning, respected Director Ma'am, Dean Ma'am, faculties and my dear colleagues. I am Dr. Sriram, Senior Resident, Department of Ophthalmology. The clinician in charge for today's clinical grand rounds is Dr. Ramanand Samanda, Assistant Professor, Department of Ophthalmology. And pathology part will be discussed under Dr. Kranti, Senior Resident, Department of Pathology. Today we are going to describe 3 cases which mimicked choroidal granuloma. We will be discussing about the approach to their diagnosis and how these cases were managed. Coming to the first patient. A 25-year-old gentleman, resident of Musafir Nagar, presented to us to our OPD on 8th of September 2022. The chief complaint was left eye sudden diminution of vision since last 2 weeks, which was painless. There was no similar episodes in past, no history of ocular trauma or surgery. The past medical history was non-contributory. The best corrected visual acuity was 6.6 in right eye and 660 in left eye. Intraocular pressure and anterior segment of both eyes were within normal limits. The fundus photo of right eye showed a clear media, disc, macula and retinal periphery were within normal limits. This is the fundus photo of left eye at presentation. In the left-hand side, the fundus photo shows a yellowish subretinal lesion suggestive of choroidal granuloma with overlying subretinal fluid suggestive of exudative retinal detachment. And you can also see temporal to that lesion there is perivascular inflammatory exudates suggestive of focal retinal vasculitis. This is a montage image that shows choroidal granuloma and focal retinal vasculitis together in the left eye. We reached a working diagnosis of left eye vascularized choroidal granuloma with surrounding exudative retinal detachment and focal retinal vasculitis, keeping in mind tuberculosis and sarcoid. The right eye was within normal limits. A retrospective history was sought and the patient was unmarried. There was no history of any cough, hemoptysis or fever, no history of recent weight loss, no history of oral or genital ulcers, no history of tuberculosis contact, and no history of any high-risk behavior. Coming to the investigations, we did all routine blood investigations including CBC with ESR, which was within normal limits. LFT, RFT and viral markers were within normal limits. Manto came out to be, in the induration size came out to be 15 mm, which was positive. The quantiferon TB gold was negative, VDRL was negative, and serum ACE was within normal limits. Even though HRCT chest showed subcentrimetric mediastinal lymph nodes, pulmonary consultation was sought and no active systemic infection was found. This is a fundus autofluorescence image taken at presentation. So, fundus autofluorescence is a non-invasive modality which is used to detect activity of choroiditis. The active areas will show white reflectivity and the healed choroiditis will appear as black. So, as shown over here, in the right eye there was no active choroiditis. In left eye, in the vicinity of choroidal granuloma and focal retinal vasculitis, you can see a white reflectivity which is called hyperfluorescence. So it was suggestive of active disease. This is the optical coherence tomography image at presentation. The optical coherence tomography is a non-invasive diagnostic technique that renders in vivo cross-sectional view of the retina. Over here, the right eye showed normal retinal contour, and this hyperreflective line is the retinal pigment epithelium that denotes a boundary between choroid and overlying retina. So over here, the choroid is pushed into the vitreous, that suggestive of underlying choroidal granuloma, and you can see a subretinal fluid over here, which is exudative in nature, suggestive of exudative retinal detachment from the choroidal granuloma, active choroidal granuloma. The clinical features obtained from our patient, that is, there was presence of perivascular cuffing of inflammatory exudates. There was a single choroidal granuloma with exudative retinal detachment, and the systemic investigation of Manto positivity showed a strong correlation, suggestion of TB uveitis. On the basis of immunological evidence, radiological evidence, and systemic and ocular features, the intraocular TB is classified into confirmed intraocular TB, probable intraocular TB, and possible intraocular TB. This classification was proposed by collaborative ocular tuberculosis study along with international experts. So in our patient, we had a single solitary choroidal granuloma along with focal retinal vasculitis and Manto positivity. So for our patient, it fell under the category of possible intraocular TB. A final diagnosis of left eye choroidal granuloma with focal retinal vasculitis, which fell under the classification of possible intraocular tuberculosis, was made, and the patient was started on oral corticosteroids 1 milligram per kilogram body weight. The ATD was not started due to paucity of other investigations. This is the serial fundus images of the left eye of the patient in the next 6-week course. With the help of oral steroids, there is gradual resolution of the granuloma and vasculitis. So as you can see this was the image at presentation. There is presence of choroidal granuloma and overlying, if you can see, look closely, you can see a overlying subretinal fluid and focal retinal vasculitis over here. So this is the image at last follow-up visit, and over here you can see the complete resolution of choroidal granuloma and subretinal fluid. This is the montage image of the patient. You can see this was the day of presentation. The best corrected visual acuity was 660. There was active choroidal granuloma and retinal vasculitis, and this is the corresponding OCT image. So at final follow-up, there was complete resolution of choroidal granuloma and retinal vasculitis, and if you see the OCT image, you can see the complete resolution of the choroidal granuloma. The major learning points from this patient: a solitary choroidal granuloma with perivascular cuffing of inflammatory exudates, that is retinal vasculitis, is an ocular phenotype strongly suggestive of ocular tuberculosis. The decision of treatment with systemic corticosteroids and/or ATD depends upon immunological, radiological, and systemic features. Coming to our next patient. A 46-year-old gentleman, resident of Haridwar, presented to us on 3rd of August 2020. He was referred to a OPD with painless blurred vision of both eyes since last 1 month. There was no similar episodes at the past, no history of ocular trauma or surgery. The past medical history is non-contributory, and there was no history of any systemic diseases. The best corrected visual acuity was 618 in right eye and 624 in left eye. Intraocular pressure and an anterior segment of both eyes were within normal limits. This was the fundus montage image of both eyes at presentation. If you look closely over here, you can see bilateral multiple elevated creamy yellow subretinal lesions, which is represented by the white arrows over here, and over here in the right eye, and over these three areas in the left eye, along with focal RPE changes over here, which is denoted by the yellow star. A working diagnosis of bilateral multiple choroidal granuloma was made, and we presumed it to be intraocular tuberculosis or ocular sarcoidosis, also keeping masquerade in mind. Retrospective history was sought. A patient was married. There was history of mild breathlessness with cough for 1 month. There was no history of hemoptysis or fever. There was history of recent weight loss. He's an active smoker, 13.6 pack years of exposure, and occasional alcoholic. And there was no history of tuberculosis contact or no other history of high-risk behaviors. Investigations was done, and CBC came out to be within normal limits. ESR was 32. RFT and viral markers were within normal limits. LFT showed mild transaminase. Manto was negative. Quantiferon TB gold, VDR were also negative. And chest X-ray showed left-sided pleural effusion with lung collapse. And for the same, pulmonary consultation was sought, and the patient was advised CECT chest. So this is the OCT image of the both eyes at the presentation. It showed multiple choroidal elevations. As you can see, this is the RPE layer, as I've explained before, and it showed multiple choroidal elevations, which are represented by the yellow stars. And adjacent to the elevations, we can see hyperintense irregularities in the photoreceptor layer over here, and pockets of subretinal fluid. This is the ultrasound of both eyes, this combined ultrasound B and A scan. So over here you can see this is the corneal side, and this is the retinochoroidoscleral complex. The red line represents the spikes of the A scan. So in this ultrasound image, you can see hyperechoic lesions within the choroid, which is suggestive of metastasis. This ultrasound helped us in ruling out metastasis from osteoma, hematoma, and melanoma. So a provisional diagnosis of metastasis was made with the help of ultrasound B scan. From ocular features, strong suspicion of choroidal metastasis from unknown primary was made, and physician opinion and detailed systemic workup was suggested. So radiological imaging was done. Chest X-ray showed left-sided pleural effusion with lung collapse, and CCT chest showed small free pleural effusion on right side and loculated pleural effusion with split pleura sign on the left side. Numerous micronodules in random distribution in both lung apices were also seen. CMRI brain showed focal enhancing punctate lesions, which is represented by the yellow arrows, in cerebellum and right frontal gray-white junction suggestive of brain mets. The pathology part will be discussed by Dr. Kranti.
Good morning, everyone. My name is Kranti, Senior Resident from Department of Pathology. So we had received a specimen of endobronchial biopsy in multiple tiny tissue bits ranging from 0.1 to 0.3 centimeters in length. So these are the microscopic photomicrograph of the microscopic images. Here we can see tissue which is lined by this metaplastic epithelium. Usually it is lined by ciliated columnar epithelium, but here we are seeing squamous epithelium. So this is the overlying epithelium, and underlying subepithelium is showing infiltration by atypical cells. It's not clearly seen here, but these are the atypical cells. Here we can see some blood vasculature, and these are all the atypical cells with high hyperchromatic nucleus and increased cytoplasm and irregular nuclear contours. Here again we can see a high power image of the blood vessel and atypical cells in the subepithelium. A few of them also had some intracytoplasmic mucin in them. We couldn't further put immunohistochemistry and categorize these cells because due to the tiny scanty nature of the tissue. So we gave a diagnosis of non-small cell carcinoma in this case. Thank you.
Thank you, Dr. Kranti. A final diagnosis of choroidal metastasis from non-small cell lung carcinoma T3N4M1C, final stage 4B, was made. He was started on chemotherapy, gemcitabine and carboplatin, and however the patient was lost to subsequent follow-ups during COVID-19 pandemic. The major learning points from this patient is the choroidal metastasis mimicking choroidal granuloma might be the presenting feature in patients with undiagnosed lung carcinoma, and ocular features may sometimes precede systemic complaints. The ocular ultrasound, high clinical suspicion, and thorough tailored systemic workup is necessary in such patients. Coming to our third patient. A 20-year-old gentleman, resident of Bijnoor, presented to us on 26 September 2022. The chief complaint was left eye sudden, painless, profound diminution of vision for 4 days. There was no similar history past, no history of ocular trauma or surgery. Past medical history is non-contributory. The best corrected visual acuity in right eye was 6.6 and in left eye was counting finger close to face. Anterior segment and intraocular pressure of right eye were within normal limits, and anterior segment of left eye showed diffuse conjunctival congestion with hypopion in anterior chamber, and it also showed AC reaction of 4+. Fundus photo of right eye presentation was within normal limits, and left eye showed dense inflammation with underlying choroidal granuloma or abscess and surrounding excretory detachment that could be barely made out. As you can see over here, it's a very hazy photo. The haziness is due to intense vitreous inflammation, and if you look closely underlying, you can see a yellowish choroidal granuloma, choroidal abscess with overlying retinal detachment. A working diagnosis of left eye panuveitis and choroidal granuloma or abscess was made, keeping in mind endogenous endophthalmitis, infectious and other causes of infectious and non-infectious uveitis. A retrospective history was sought, and past history of fever 12 days back, which lasted for 3 days, was there, and the patient was admitted at a local hospital for 1 day and intravenous medications were given. There was no history of any cough or hemoptysis, and no history of any significant major illness at the past, no history of TB contact, or no history of any high-risk behavior. Ocular ultrasound of left eye was done. It showed multiple hyperreflective pinpoint and membranous echoes in the vitreous cavity, which is suggestive of vitritis or exudates. And focal dense hyperreflective echo at the center of the posterior pole was seen, which was suggestive of subretinal abscess with surrounding neurosensory detachment. The patient was admitted on the same day, that is on 26th of September. Vitreous tap was taken and intravitreal vancomycin of dose 1 milligram per 0.1 ml and ceftazidime of dose 2.25 milligram per 0.1 ml was given under topical anesthesia on the same day. The same Vitreous tab was sent for microbiological examination, that is gram stain, KH smear and culture. And the patient was started on intravenous ciprofloxacin 200 milligram twice a day, along with eye drop moxifloxacin 0.5% 1 hourly, eye drop prednisone acetate 1% 1 hourly, and eye drop atropine 1% 3 times per day. Systemic investigations was done, and CBC and fasting blood sugar within normal limits, LFT, RFT viral markers were also normal. Imaging of chest X-ray was done, which was normal, and ultrasound whole abdomen was also done, which was also normal. Manto, quantiferon TB, and COVID RT-PCR were negative for this patient. Blood and urine culture and sensitivity was done. There was no growth of any organisms. Vitreous tap and smear, tap smear was sent for smear and culture. There was no growth in that also. The 2 days following intravitreal injection, the vitreous inflammation increased and subretinal abscess continued to worsen. So a decision of left eye pars plana vitrectomy was taken. The patient underwent left eye pars plana vitrectomy along with a repeat injection of intravitreal vancomycin, ceftazidime, voriconazole and dexamethasone on the same day, that is on 28th of September. This is a short surgical video showing the vitreous biopsy as well as pars plana vitrectomy. So before starting any pars plana vitrectomy, we have to make 3 scleral ports. One port is for infusion cannula. This is the infusion cannula that is placed on, and the other 2 ports are for endolite and vitreous cutter. So normally retina can be viewed, but in this patient, due to intense inflammation, the view is unclear. If you look closely enough, you can see yellowish halo, which was suggestive of a choroidal abscess. Optic disc could be made out faintly. So vitreous biopsy was taken and core vitrectomy was done, and the ports were closed at last. So a final diagnosis of left eye endogenous endophthalmitis was made, and we perceived it to be fungal. It was due to the clinical picture during the clinical picture in the intraoperative time, and the source was assumed to be the contaminated intravenous fluid or line the patient was given when he had fever. On postoperative day 3, that is on 1st of October, the vitreous inflammation was on decreasing trend. Exudative RD has decreased. Tablet voriconazole 200 mg BD was started, and oral corticosteroid 20 mg was started in order to counter the intense inflammation. Topical eye drops were continued as before. So in this image, as you can see, the media is clearing, and you can almost make out the choroidal abscess. This is the picture of postoperative day 5. That is on 3rd of October. The vitreous inflammation continued to improve. A repeat dosage of intravitreal vancomycin, ceftazidime and voriconazole was given. Tablet voriconazole was shifted to maintenance dose of 100 mg twice a day, and low dose oral corticosteroids were continued. So this is the serial images of the patient showing improvement. So if you see on 4th and 6th, there's a lot of overlying retinal hemorrhages along with a large abscess, and if you can see close enough, you can also make out the vascularization. So following treatment, gradual resolution was noted on the image on 21st. So it shows a organized fibrotic scar at the posterior pole, temporary to the scar, you can see the exudations are loosening up. This is a comparative montage fundus photograph of the left eye. It was counting finger. He was having a vision of counting finger close to base on 1st, that is postoperative day 3, and this is the last follow-up visit, and he had a vision of 660, improved vision of 660 with the gradual resolution of choroidal abscess, and the abscess was turned into a fibrotic scar. This is a short treatment course summary. The patient was admitted on 26 with dense vitreous inflammation choroidal abscess. The first dose of intravitreal antibiotics were given. On 28th of September, no improvement was seen. The patient was planned for pars plana vitrectomy, and oral voriconazole was started on the next day. On 3rd of October, that is on postoperative day 5, subsequent days showed improvement in media clarity, and a repeat dose of intravitreal antibiotics and antifungals were given, and the inflammation decreased, abscess was resolving, and vision improved up to finger counting at 1.5 meter, and patient was discharged on 8th of October. The major learning points from this patient are clinicians must be aware of endogenous endophthalmitis in setting of risk factors like recent hospitalization and intravenous medication in absence of any ocular trauma or surgical interventions. Early treatment with intravitreal antibiotics and pars plana vitrectomy is necessary, along with treatment of primary focus to salvage vision. So I would like to conclude by saying a variety of ocular and systemic diseases may present with choroidal granuloma or mimicking phenotypes. A multidisciplinary, holistic approach is of utmost importance for early diagnosis and management in such cases. I thank and I acknowledge all of my faculty, senior and junior residents of Department of Ophthalmology, other departments of AIIMS Rishikesh that helped us to make this diagnosis and concerned patients and their families. Thank you.